In addition to a gait analysis, Mr. Stewart was asked to perform several sit-to-stand transfers in order for the therapist to identify any other deficits that may also be contributing to Mr. Stewart's instability and decreased independence. The action will be described phase by phase. In flexion momentum phase, there is an inability to move the center of mass over the base of support. This is primarily due to Mr. Stewart's inability to symmetrically distribute his weight throughout bilateral lower extremities. The left lower extremity is situated more anteriorly and externally rotated as compared to the right. Mr. Stewart must shift the majority of his weight onto both his right upper and lower extremity due to the non-weight-bearing position of the left lower extremity. The right side must generate the majority of the force during this action, and it takes Mr. Stewart several attempts to accomplish this complex movement. Once Mr. Stewart leans far enough to the right to unweight the left side, the left buttock begins to lift from the mat, eventually followed by the right buttock. Instead of the buttocks naturally lifting off the chair as a result of momentum as the center of mass shifts in front of the base of support, the right arm and leg must now compensate and initiate the lift. In momentum transfer phase, there should be increased dorsiflexion, slight initiation of knee extension, slight hip extension, trunk flexion, and shoulder flexion. There is virtually no involvement from the left side of the body. There is no movement in the left lower extremity into ankle dorsiflexion, knee extension, or trunk extension. All of these motions are exaggerated on the right side to compensate for the lack of assistance from the left. In extension phase, there should be ankle plantar flexion, a continuation of knee extension, hip extension, trunk extension, and shoulder extension. However, full extension is never reached by the entire trunk and lower extremity. This is primarily due to asymmetrical weight distribution throughout the entire transfer. Mr. Stewart remains in a forward flex position which never allows him to completely gain his balance. This places him at an increased risk of falling. The final stage of sit-to-stand is achieved once the hip is fully extended and all motion associated with stabilization concludes. We should see neutralization of all joints. With Mr. Stewart, the body is unable to stabilize itself in the stabilization phase. He is actually forced to take a couple of steps forward to regain his center of mass within his base of support and thus stabilize himself while his right side still accepts the majority of his weight. After assessment of Mr. Stewart's sit-to-stand transfers, Mr. Auberly, the physical therapist, began to compose a treatment plan focusing on improving Mr. Stewart's ability to transfer weight symmetrically during the task. The therapist begins by repositioning the patient's left lower extremity. The therapist then asks Mr. Stewart to pick up his left hand with his right hand and place it on his knee. The two then lean onto his left side. This helps Mr. Stewart to better sense the transfer of weight onto the affected side. Mr. Auberly progresses the exercise by asking the patient to reach and lean even farther to his left affected side by placing both hands on the therapist's left knee and performing a similar task. These two tasks are performed repetitively until the patient gets a good sense of appropriate weight distribution through the affected side. One other technique the therapist uses to facilitate symmetrical weight distribution is placing the unaffected side at a disadvantage while performing the task. The therapist places a low step beneath the unaffected leg. This forces the patient to distribute weight through the affected lower extremity in a more symmetrical manner. The technique can be performed initially using a mirror for more visual cueing. However, the treatment should progress to the point that the patient no longer needs visual cues. These techniques will encourage symmetrical weight distribution through repetitive practice until the patient is able to perform the task without assistance or cueing from such techniques.